Dr. Steponavičienė, radiation oncologist from National Cancer Institute. So please welcome. She will talk about local treatment of the primary tumor in the metastatic castration-sensitive naive situation. So please.
Yeah. So we'll start, and it's my pleasure to participate in this conference. And today I would like to focus on local treatment of the primary tumor with emphasis to radiation therapy, of course, because I'm a radiation therapist. And we'll talk about metastatic prostate castration-sensitive cancer. A quick reminder, prostate cancer, de novo diagnosed prostate cancer, has a poor prognosis, about 3 to 4 overall survival, 3 to 4 years, and the mainstay treatment of metastatic prostate cancer, of course, is androgen deprivation therapy. Can I see my next slide? Yep. And metastatic castrate-sensitive prostate cancer is a cancer that has spread beyond the prostate, and it is controlled by lowering the amount of testosterone in the body. As we all know, treatment... This one? Yep. Okay. Yeah. The treatment is, as I said previously, is ADT, androgen deprivation therapy, but unfortunately, as we all know, the relapse is inevitable in about a median time of 11 months. So we have to look for some more treatment opportunities, and the treatment landscape of metastatic prostate cancer has rapidly changed with an early use of docetaxel and abiraterone and prostate radiation therapy to the primary site. As we all know, we have a metastatic disease. So what is rational for local treatment in this setting? And I would like to remind you that the primary tumor is a source of metastatic cancer cells. So we have to cure primary tumor. Also, primary tumor is a site for development of resistant clones. And halting the progression of the primary tumor can prevent the development of symptoms and prevent for need of palliative interventions. And also, radiation therapy has an immunomodulation effect. When we irradiate primary tumor, we can radiation therapy damage tumor cells, which leads to an activation of immune response. And the abscopal effect is also well recognized in oncology. What options of the local treatment we can offer to our patients? Of course, radiation therapy, surgery, or cryoablation. My topic is radiation therapy, and I would like to show some trials, most of them are randomized, and some of them are non-randomized trials. So in the group of non-randomized trials, we know about most prominent 5 observational studies that conclude that radiation therapy has a survival benefit. When we add radiation therapy to primary tumor, we have survival benefit, but all non-randomized trials all data from non-randomized trials must be taken with cautious, because those trials are retrospective, and that's why we should have a look to prospective randomized trials. And we have most prominent HORAD trial. Stampede trial is the biggest trial in this group, And 3 of the other trials are still ongoing, and we are still awaiting results from them. Once again, trials HORAD and STAMPEDE, they have finished recruiting patients, and we have results. And stopgap meta-analysis is based on them, and piece 1 on SWOG trial are still ongoing, and we are waiting for results. And I actually would like to point out that there are 2 trials, CHARTED and LATITUDE, who in those trials we have data about prognostic factors, and we can stratify prognosis, and we have groups of patients with low or high metastatic burden disease. And HORAD trial, look a little bit closer to this trial. It's well balanced, nice trial. We recruited about 400 patients, and 200 of them received ADT, and the same amount of patients received ADT plus radiation therapy to primary site. And most of patients had PCA more than 120 nanograms per milliliter, and about 67% of them had 5 or more bone mets. And what results do we have? In terms of overall survival, actually there is no impact of radiation therapy, there is no survival benefit, but in terms of biochemical progression, time to PCA relapse is in favor in radiation therapy group, 15 months versus 12 months. And when we look a little bit closer to subgroups of patients, we see that most impact or most benefits there are in groups which had less than 5 mets and had no bone pains. STAMPEDE trial is multicentric, multi-stage clinical trial. Patients were recruited in UK and in Switzerland. We have huge amount of patients, more than 2,000 patients, and also the same, some of them received ADT and some of them received ADT plus radiation therapy to primary site. And the results, what are results? The results are more or less the same as in HORAD trial, that in terms of overall survival, actually radiation therapy plays no significance. It's not very beneficial, but in terms of biochemical progression, radiation therapy is statistically significant. And on the basis of those 2 trials, stopgap meta-analysis was made, and results actually the same, that if we have metastatic prostate cancer with low burden disease, those patients will benefit from radiation therapy in terms of biochemical progression, and some of them in selected groups, some of them will benefit in survival as well. That's why we have recommendations that comes from ESMO and from European Oncology Association. Those recommendations are quite strong, with quite nice evidence level A, grade 1, that offer in metastatic prostate cancer add radiation therapy, but those patients must be selected, and selection is based on CHARTED trial. So I mean, in a low burden metastatic disease, radiation therapy plays a quite nice role and should be added. It's a recommendation. What were requirements for radiation therapy? In HORAD trial, we see that it was irradiated only prostate and seminal vesicles, but in STAMPEDE trial, a clinical target volume as well as planning target volume included lymph nodes as well. That's why STAMPEDE trial is like an example for radiation therapy, that it must be included regional lymph nodes, prostate, of course, seminal vesicles, and radiation dose must be definitive, and of course it must be IMRT and preferable image-guided radiation therapy. Radiation toxicity actually was not pronounced so high. Radiation-free toxicity was, as I mentioned, quite low. In 6 months post-treatment, there was only 1% increase of grade 3 radiation toxicity. So in summary, I would like to conclude that it is a recommendation, quite strong recommendation, to add radiation therapy to ADT in metastatic prostate cancer. Still, we have to keep in mind that we treat patients with M1 disease. We treat metastatic disease. So to think that we will cure local disease and everything will be okay, we will make mistake. So that's why the toxicity, minimizing toxicity must be paramount for us. And also I would like to point out that radiation therapy is biological different treatment if we want to compare with operation, with surgery, because as I said previously, radiation therapy has an immunomodulation effect, and this effect is not well recognized in surgery arm. Stampede trial has confirmed that once again that radiation therapy provides the most cost-effective and less toxic method for delivering life-prolonging therapy in metastatic prostate cancer. Actually, in hormone-sensitive M1 patients, symptomic events are quite rare, and we have to keep in mind also this one. And once again, median survival, in terms of survival, median survival was not significantly different when we add external beam radiation therapy to ADT. And what future directions I would like to point out that long-term data from Stampede trial will be helpful to understand whether prostate RT will ultimately reduce long-term local symptoms from progression. Also, it is very important timing. When should we apply radiation therapy? With ADT or a little bit after ADT, it's very important because we're looking for better results for our patients. We are awaiting results from PEACE-1 trial, but those results will be on 2030, so we'll have to just wait around 10 years. Also, we'll wait for results from SWOG trial, and it will be also in 10 years. Till that, we have to cure our patients and to keep in mind the best practice that we have now. And the benefit of treating metastatic sites has recently gained much attention from trials suggesting a potential overall survival benefit such as BRT. But I think this will be lecture all about SBRT for in oligometastatic disease, and the results are quite very good. And long-term data will be important to determine the frequency of local symptoms. For example, urinary obstruction or hematuria without local therapy. So that's all I have for today, and I hope you will enjoy radiation therapy and radiation therapists as well.
Thank you very much. So maybe from the audience, no question, and I see no virtual questions. So again, thank you very much.
Thank you.